Welcome back to this video series as we continue our third discussion on management of cardiac surgical arrests. I'm joined once again by our expert panel, Tara Bartley, John Whitlock, and Christina Segura-Ruiz. We're discussing today the protocol for management of shockable rhythms. So this would include ventricular fibrillation or VTAC without a pulse. And the process that is outlined in the algorithm is shown here. The treatment is first to recognize that this is a shockable rhythm. Follow that with 3 rapid sequential shocks. CPR is then initiated and antiarrhythmic is administered, and repeat shocks may be administered after 2 minutes. So that's the algorithm. I'll start with Christina. The initial part of this algorithm is really recognition of this rhythm as shockable. And that can be tricky sometimes. What guidance do you offer new responders on how to make this diagnosis?
Yeah, hi Jill. So I think this is probably the most difficult for responders. It becomes a bit tricky when we're talking about shockable rhythms, because it's easier to see a flat line, I suppose. And at least after cardiac surgery, there is lots of rhythms that they can be confused. They can be very confusing, atrial fibrillation, fast rhythms. So for shockable rhythms in these situations, I over the experience over the years, I found that responders they get a bit mixed messages. I think sometimes I know Carl's at the beginning it was 2 days course and include the ECG recognition, and sometimes that's probably what you need to do. Just bring some of the ECG and go through some of the rhythms, and then people get more comfortable with them, and that's probably what sometimes you need to do. Just bring that and discuss what's a shockable rhythm. It's still difficult to kind of embed it in all our staff, not to jump into someone's chest and just do the 3 shocks. I think that's probably the next probably most difficult thing to find, is still, because we had this embedded in our training for many years, and that you have to jump into somebody's chest, and that's the second most trouble to change people's minds. So, but I think that, yeah, to bring a bit of a training extra, that's probably one of the recommendations I would.
Good. So clearly the EKG training and the recognition is essential for people to recognize when you can shock and when you can't. John, do you have anything to add? How do you make sure that your staff are really keying into those shockable rhythms?
Well, Chris, similar to what Christina does, I do frequent mock open chest where we review different rhythms and reinforce that with newer staff, especially. I in my program try to emphasize streamlining the process of identifying a shockable rhythm, not confusing it with a paced rhythm, and recognizing that we have other data at our fingertips that many ICUs don't, in terms of PA lines, A lines, and other pressure waveforms. So when we see what looks to be like a shockable rhythm and flat lines across with all the pressure waveforms, I teach my staff to trust that.
Good. Thank you. And Tara, I know we've taught these courses before, and one of the key things I've heard Joel say is just don't miss it. You know, he's seen situations where people were trying to pace something that was shockable. Anything that you can do or that you teach your team members to really key into that?
Yeah, I mean, I kind of concur with what Christina and John has said. So it's about teaching the staff and giving them confidence. But in the initial instance, when a patient's rhythm is abnormal, it is either shockable or non-shockable. If it is the shockable side, we just need to make sure that, as John said, everything's flatlined. In a traditional ALS, you're taught to look, listen, and feel for 10 seconds. In our situation, there's probably much more sort of a cardiac cause that's put somebody into a cardiac arrest. And so we don't encourage the look, listen, and feel for 10 seconds. We encourage the look at all lines, and if all lines are straight lines, it's very likely to be that the patient has lost output. If you're then looking to see if somebody's in asystole, it is just worth just checking that the pacing is turned off so that you're not missing an underlying VF. There was at least 2 researched evidence cases where people were treating an asystole and actually it was an underlying VF. And we know that VF is a much more accessible rhythm to get ROSC, return of sinus rhythm back. So don't miss that. And I think in terms of the teaching, confidence-wise, do rhythm recognition and keep it simple. So, you know, if patient's got an output, then you can have a much more complicated, complex conversation about, is it fast? Is it slow? Is it narrow? Is it broad? Are they compromised?
Good. And again, I think that's one of the beautiful things that the algorithm teaches us is basically it's not to diagnose this fast rhythm as, you know, WPW with aberrant conduction, but just to say, is the patient stable or not? And if they're not, to proceed with your shocks. And also not to cause an arrhythmia through pacing. And I think that's another thing that comes out in the pacing lectures is that if you don't know what you're doing with a pacemaker, you can actually induce VFib if you're not careful.
And I think, Jill, just to add, I think we need to be very careful between the patient with no output and being a shockable rhythm to the patient that has got an output but needs a cardioversion. And perhaps that's something we should talk about at a later date.
Yeah, absolutely. Thank you. And so we do get into those nuances about, you know, what is the best approach and who can cardiovert and who can defibrillate. But that is a more detailed discussion. I'll come to a simpler question. I'll take this one to John. In the algorithm, it doesn't really specify an energy dose or sequence. How do you manage that? What energy dose do you use? And does your staff use manual or automated defibrillations? And that may differ, I realize, in areas of your hospital, by unit.
Thanks for throwing this my way, Jill, because what seems simple isn't always so simple. And this one is kind of a passion of mine. Resuscitation science is always evolving because it's difficult to stratify and pick patients. We can't pick patients and not save them, right? So the evidence that we receive is often just based on initial case reports, and it grows from there. The amount of joules that are used in a true shockable cardiac arrest is evolving as well. I teach at my hospital that just goes straight to 360 joules for a few reasons. Number one, in the United States, the American Heart Association recommends to follow the manufacturer's guidelines. Well, who's looking up what the manufacturer's guidelines are? They also say at the same time, if you don't have manufacturing guidelines available to you, just go to the maximum joules. So that gives me, in my mind, permission to just go straight to 360. The other piece to this is picking the highest amount of joules right from the get-go gives people just one number to remember. They don't have to worry about more steps than are necessary. And there's a body of clinicians that are moving towards the concept of just if your patient is in a shockable rhythm and has no pulse, it's unresponsive, is talk in the background of those being the recommendations in the near future. So that's my complicated answer to your simple question.
Thank you. So I'm hearing you use the maximum joules for all of your shocks from the initial defibrillation. Tara, is that what you see practiced?
So I think, again, as John says, it's complex, but it's not complex. I mean, you default to what the manufacturer says. You default to what the governance is in your organization. And then you kind of work out whether or not it's maximum or whether or not you are actually doing, in our case, mostly it used to be that it was unipolar, it's now bipolar. The important thing is to recognize that you need to give the 3 shocks in 45 seconds. The evidence suggests that impedance reduces as you deliver the shocks one on top of each other, and that you follow protocol. So my experience is usually it's 150, but I have also experienced 360. So I'm not sure. It'd be interesting to see what Christina says from sort of the north part of the UK.
Okay. And is that manual defibrillation? Because if you're talking about delivering those shocks that quickly, you're not waiting for an AED.
So I think in our cohort of patients, we do not use AEDs because our patients are in a high intensity situation, be that in the ward or be it in the intensive care, with a knowledgeable group of staff. AEDs are aimed at the community and for staff that are not familiar with resuscitation. So again, it's following your own code of conduct. Do not deliver and use a piece of equipment you're not confident with. If AED is the alternative, then it's better to go ahead and treat, but that's not going to happen in any of the units that we work in. Looking after the post-operative patients, there will always be someone there able to deliver.
Thank you. And Christina, now I'll ask you, what sequencing of shocks are you seeing in your area?
In my area, my hospital is 150, but I will say, like Tara, you need to use the energy that is under your protocol. And again, I think we discussed this several times, is what you agree as a team. So, and I think that should be on your calling protocol guidance, whatever you are agree with your research, with your own team. That's what you need to do. Whatever number is, I don't know, data related. Probably John knows more about the data on that matter, but that probably is a new research that we should do. Would be some ethical considerations, but anyway, I think in the other side, regarding manual or automated, as Tara said, I think in a highly environment, everyone use. And they can put the joules, they can do it manually. In theater is the same, you know what's the joules because you use it very often, I would say, or more often than another parts. And as soon as you go away from this high care, you find teams that are less capable to recognize the rhythms that we said before. So they need the machine to tell them when is a shockable or non-shockable, and they need the machine to do the job for them. And that's when you see, especially on the ward, you see that the staff is using automatic defibrillators, which in some ways is probably what it should be, because it's safer. Yeah, because these teams, they are not in those situations as frequently as staff on ITU critical care. So yeah, I think probably is the safer thing. So what we do in our hospital now is we add into our CALs staff on the ward, because sometimes they come to HDU to help out, and then is when they get really stressed because they can't really, they feel like they can't help. So that's what we've been doing recently. We just add in ward staff and give them the other side of this training, which I think is quite beneficial.
Well, that takes me to my next question.
Jill, I was just going to say, sorry to interrupt. I was just going to say the other thing is it depends on the staffing on the ward. If you've got a ward with a team of advanced practitioners on, then they will automatically be able to, do the whole protocol, etc. Sorry to have interrupted.
No, that's okay. It made me realize that, that takes me right to my next question, which is what are the differences in your training and your protocols for your step down areas and your critical care units? So, in our step down area, we now are using some AEDs. I'm trying to change that. But again, I think, there are differences. We've not invited all of our step down nurses to that. We rely on our ICU team to go and be those providers, but we do offer some courses on arrhythmia recognition and pacemaker management. So, Christina, are these the same protocols then that you would follow in your step down areas, the same training, or are you doing that a little differently for that team?
In my area where I work, is different people, but they kind of work together in some way. So they spend some time going to ITU. So they kind of rotate around the service called critical care, with a step down is included. And then the protocols for CALs are the same. And when we had, as you know, if you have a cardiac arrest with a reopening on a step down unit, it's chaotic because everything needs to be kind of transported into this step down area, and the staff they don't have the highly tech that you need probably. I think the protocols are the same. On the ward, That's why we brought the teams into CALS, because we think it will be beneficial for them, not because we have many reopenings on the wall, but if they need to come and help out, at least they can feel that they can do that. And again, you can have a patient day 10 with a cardiac arrest. You don't do a reopening, but your protocol, in some way, apart from the reopening, will be recognizing the shockable and non-shockable rhythm. So you really need to train them. The only thing I realized when you go into another sentence is that people tend to check the defibrillator machine, but they don't know how to use it because they just check it. They don't kind of play with the machine. So I will say, please go. And when you have 5 minutes break or you're not doing anything, just go and have a look at the machine, look at the settings. It's really important, especially if you are a nurse who in other centers that you may rotate between different units, or you may work in different hospitals with different protocols.
No, I
You need to be
absolutely-
aware of those.
Yeah, absolutely agree. Tara, are your protocols and training similar for these step down areas? Do they attend your classes? How does your team manage that?
Yes, I mean, the protocol is the protocol. So you need to follow the protocol and you need to have the right people being able to manage it. Historically, CALS has always been welcoming of people across the sort of the ward area and their ITU stroke step down areas as well. And I think it's for your individual unit to make sure that that training is sustained and is continued in a way that, you know, makes staff feel comfortable. So I think in terms of, how you run it. The key question here is about environment. Where do you reopen? If a patient has a problem and needs their chest reopening, where is the decision to do the reopening? And that depends geographically on what your unit looks like. If your unit, in terms of the ward area, is right next to the ITU and closely associated to theatres, then you've got options in terms of theatres and you've got options in terms of using the ITU space. And you've also got options of having those staff that are populating those other areas readily available to help. If you find in some hospitals, you know, you're 3 floors different, then you as an individual hospital need to make your assessment from a patient safety and a staff safety point of view in line with the aspiration to be in the chest within 5 minutes. Do you open on the ward or do you take the patient back to the more acute area? And again, there is no hard and fast rule, but you do need to have exactly the same protocol and the aspirations to be able to achieve it, I think.
Thank you. John, are you training your step down areas in a similar manner to your ICUs, or do you have a different management approach?
Yeah, well, actually, that's evolved over time. When I first started teaching the protocols, I actually offered the step-down unit nurses much more than I offer now. I've learned over time to streamline the process because it was too confusing for them to understand what their roles might be in something that maybe occurs once every 4 or 5 years. So that was something that I learned along the way. A pearl that I would highly recommend for centers that are considering training the nurses on the step down unit is to replicate the carts that you provide to the ICU so that the staff that will be assisting with the reopening know where things are. They should be identical. Then the last thing I would say is word of caution. We teach that the cutoff for considering resternotomy is about 10 days. That's somewhat of an arbitrary number as we've learned over the years, but patients at day 5. So I did have one situation where a patient was sitting in a recliner in their street clothes with all of their IVs removed, and they were ready, waiting for their family to pick them up. The patient arrested, and we proceeded, and there was a lot of the staff that were present wanted to move pretty quickly to resternotomy, but in a patient that has no large bore access, I would be highly, highly cautious to open a chest and potentially tank a pressure that you're not going to be able to treat without large bore IVs. So move with caution is my biggest.
Well, you're making the same point that Tara did, which is, the environment that you're in is absolutely critical. And just briefly, when we brought this out, we did a survey and reviewed our data. And in the past 5 years, we had only one event that occurred in our step down unit that was a reopening event, but we'd had quite a few shockable events and paceable events. So that was what we focus on with the training. The COWS response is left with the ICU team who responds, and yes, they have the same equipment, but for a shockable rhythm or a paceable rhythm, our step down unit should be able to manage that themselves before the code team gets there. So
Jill, I think it's really important, isn't it, to work out that our cohort of patients are very likely to have a reversible cause in the early days post-operatively. That's an iatrogenic cause relating to what we've done to them. And therefore, by opening them, you are going to have a better resolution. I think both Christina and John quite rightly have alluded to the, when do you not? So the 10-day rule, which is arbitrary, if somebody arrests at 10 days, it is more than likely not related directly to the cardiac surgery they've had, and is more likely that we recommend therefore you follow the ALS protocol. Now, obviously individual units need to make that decision, but at the end of the day, it is around timing as well as environment and working out whether it's shockable or non-shockable and whether you should be going back into the chest.
I think just to add what Tara and John is saying, and you, Jill, as well, is anyone who wants to do CALS in the center, they want to bring CALS as a training in the centers, probably the best thing is to kind of walk through where is your theater, where is your step down, where is your ITU, or how the teams are going to coordinate themselves. Sometimes just do like a practice to that's what we've done in a few centers. That's the first thing that you do, and then you realize all the potential issues that you can have, and then all the conversations that you may can have as well.
And I also think that the course also covers the deteriorating patient and the other scenarios prior to needing to open someone's chest. And you are probably equally, advised to concentrate on those aspects of care with all the people that are going to be involved. And currently, if you've got somebody day 3, day 4, and they're on the ward and they start to not look right, then actually it's about looking at the sort of, the assessment of a patient and the differential diagnosis, treating any immediate action, looking what diagnostics you need to underpin exactly what is going on, and avoiding having to go back in and open a chest because there's been not enough action early on.
exactly. I think that's a great point, is that early recognition can, prevent a great many of these events. I'd like to just follow up now with one more question. I think your answers to this might be fairly quick. There are two things that have kind of made their way into the American Heart Association algorithms here. One is lidocaine, and that is basically it can be used in lieu of amiodarone. And the other is something called double sequential external defibrillation. And this was approved for refractory ventricular arrhythmias. And this would involve putting 2 sets of defibrillator pads in different vectors, so an anterior posterior and an anterior lateral, and then connecting those to 2 different defibrillators, and then in quick succession, offering 2 shocks. Now, again, both of these are fairly new. Is this anything that you're seeing in the cardiac surgical population, or is this really in the medical literature? Christina, are you seeing either lidocaine or double sequential defibrillation for refractory arrhythmia?
It's going to be enough for me. I haven't seen that, but it will be interesting to read about it. I may have to look tonight.
John, are you seeing any of these in your units?
Not,
That's a
not
no.
at all. But what that I struggle with sometimes is administering an antiarrhythmic when the staff are getting to the point where they're thinking about resternotomy. They tend to focus focus on that force.
Yeah, the drug administration and other things I think can be a big distraction. Tara?
Mm-hmm.
So my answer is no, and I think you need to put it in context. I think you need to think about the research that's out there, both for Lidocaine or Lidocaine, depending on my audience here, and the double sort of shocking, are both sort of perhaps in the cohort of patients that are non-cardiac and actually in the out of hospital arrest or in the refractory arrest situation, not in the patients that have just had cardiac surgery. So no, we're not seeing either. I think if you are in a high-tech situation and you are further down the line and you are not having response to the amiodarone, which is the drug of choice, the drug of protocol, and the drug we should be using, then a more expert consideration can be given to Lidocaine possibly, but it's not something we're seeing.
Thank you. Yeah, or if we say there was an allergy or a patient, couldn't tolerate the drug or something like that. It's good to know that you have an alternative.
Yeah, you don't want to get a rhythm back and end up with a sort of a long, prolonged QT and cause something else afterwards.
Thank you. Last week, our final question was whether or not any of you advocate artificial external compression devices for delivering CPR, and you all said no. So I wanted to follow up with that. There is no data that either company was able to produce about using these devices in patients that have a recent sternotomy, but they also don't offer specific contraindications. What both manufacturers have stated is that these devices are safe to use on any patient that you would do CPR on. So I think that's an important aha moment. And so I just want to ask, do any of you have policies that specifically ban the use of these devices in the cardiac surgical population? I assumed that they wouldn't be used because of manufacturers' guidelines, but there are no manufacturers' contraindications. So we've now added a policy that says that these devices can't be used on patients after a sternotomy. Is that something, John, that you have done or that you see a need to do?
We do have a policy about the use of the mechanical CPR device is not recommended at our hospital for at least 90 days after sternotomy. Cardiac stars stand on it. Recently, we had a patient that had a non-cardiac surgery related decline that basically was going into failure and really required, and that patient, the team decided that mechanical CPR might be the best choice because he would be getting CPR for such a prolonged period of time while we were placing the ECMO. So that's what we intended. That was the first time we'd ever done that. But I throw it out for consideration because I think that wasn't a bad decision.
Yeah, I think the concern is really a fresh sternotomy, and a patient that you described that's going to have a prolonged resuscitation is exactly who those devices were designed for. Tara, do you see a use for these devices, or do you have any policies against them?
No, I think across the UK, I'd be interested if Christina agrees, the devices are used in the community. They're used when patients are being brought in and out of hospital arrest situation, and they then tend to be used within the ED department thereafter. They're not often used in hospital cardiac arrests, and we certainly are not advocating and do not use them in the cardiothoracic patient with the new sternotomy for fear of, the immediate damage to delicate swollen tissue that's been sutured, to possible damage to the sternal bone and the heart tissue, and then also the longer side effects of osteomyelitis, etc.
Thank you. Christina, is this something that you've seen in your institutions?
I agree with her. So these devices are used in cath labs when patients they come with an STEMI or in A&E. And again, for prolonged CPR, our patients, they don't have prolonged CPR. They should be reopened. So it kind of contradict the whole concept of CALS, because by the time that you put this device on, which is, it doesn't look simple to me. I mean, I haven't put any, but I've seen it in a few times. You're ready to reopen. So I don't see the concept of external CPR on the patients that we're discussing, on our patients. So because what you want is to minimize your CPR and just open and have a look what's inside, or shock or massage, internal massage. So the concept of this CPR external compression, I don't see it's a point for our health. That's my
I'll reiterate that the society has definitely stated in the guideline that these should not be used on a patient who's had a recent sternotomy. So I think we're all in agreement in supporting that. But we certainly have seen them used in the cath lab and you know, a patient that's being put on ECMO or something like that. So again, thank you for your comments about that. And so as we conclude, I wanted to, you know, give you one more question to lead us into next week, where we'll be discussing bleeding and tamponade. So again, one answer. I'll start with you, John. We've been taught that nurses are not supposed to strip chest tubes, but in the event that your patient is suffering a tamponade, would your nurses proceed to strip chest tubes in reality? Yes or no?
Yes.
That was Christina.
Well, we had the first nurse in our center, so so yes, our nurse is a yes.
That's a yes. Your nurses would strip chest tubes. Tara?
It's not in the protocol, it's not recommended, but so you don't knock off a clot, isn't it? Whereas if they're already clotted, then you need to do what you need to do to try and restore sort of, you know, activity from the heart.
Yep. Okay. So basically, and I would say that yes, I've certainly not only seen nurses strip chest tubes, but taught them too. So you know, when, as you said, when your patient's dying before your eyes, you do what you think you can do to support them. Although our surgeons did always admonish us not to take something that was their problem and convert it into our problem.
Yeah.
So with that, I will once again thank my expert panel, John, Tara, Christina. You guys are fantastic. I really appreciate picking your brains and sharing your vast expertise with our audience. Thank you so much for joining me, and I will look forward to seeing you again in 2 weeks, where we discuss the complex problem, double sorted, of bleeding and tamponade. So I'll look forward to having you join us then. Thank you very much for being here today.
Thank you. Good night.
Thank you.
Thank you, Joe.